Good afternoon. First off, I'd like to acknowledge Captain Ignacio, our program director, for his commitment to resident participation in missions like Pacific Partnership that you heard Dr. Brill talk about earlier today. Thanks for the opportunity to talk about our experience with multimodal pain control in the humanitarian setting. I have nothing to disclose. So, any conversation about humanitarian surgery either starts or ends with a discussion of the ethical considerations or barriers when providing surgical care somewhere where infrastructure is limited and follow-up care is not known. Throughout global surgery literature or humanitarian medical mission literature, the barriers and ethical considerations are highlighted. Some of these include challenges with informed consent, language barriers, cultural differences, standards of care, medical infrastructure, local regulations or restrictions, differences in the disease presentation, the lack of follow-up care, and of course, management of complications. The challenge I address today is pain control after surgery in this setting. As Dr. Brill explained during his talk this morning, Pacific Partnership is a mission conducted on board the USNS Mercy throughout Southeast Asia. In 2016, Pacific Partnership visited 5 countries. There are many facets to this mission, but the surgical mission included general, plastic, and pediatric surgical specialties. As a resident, I was afforded the opportunity to participate in the surgical mission in 2 countries, East Timor and the Philippines. One of the many previously mentioned barriers we encountered during our mission was the use of narcotics. The use of narcotics in this setting presents a unique ethical challenge. There's potential for adverse events, the absence of reliable follow-up in opiate-naive patients, and considerations of local policy. These were challenges that were very apparent during our time, first in East Timor. East Timor prohibited the distribution of any narcotics off of our hospital ship. They have very stringent regulations in place governing the providers within their country, and they actually require a special license for the distribution of controlled substances. This special license is not easily obtained, and it was highlighted by the fact that only one provider possessed this license at their national hospital. So these restrictions forced us to develop a strategy for multimodal pain control. This is not a novel concept or strategy. However, rarely do we operate confined to narcotic-free postoperative pain management. All patients were pre-admitted the day before surgery. All patients stayed overnight after surgery. There was no same-day surgery. We utilized intraoperative and postoperative acetaminophen and NSAIDs, as well as liberal use of local anesthetic. No patient had PRN narcotics ordered during the recovery phase, with the idea that if a patient were to require a higher level of pain control, a phone call would have to be made to the surgeon who would evaluate their pain needs before giving appropriate medications. All patients underwent post-op pain evaluations by the surgeon, and the strategy was implemented first in East Timor because of those stringent regulations, and due to its perceived success, was continued during our surgical mission in the Philippines. So to review our experience with this strategy, we retrospectively looked at all elective general surgery cases in adult patients performed by 3 staff general surgeons and 2 general surgery residents. This included both open and laparoscopic cases, and we excluded any of the cases that were performed in host nation hospitals. A total of 41 cases were looked at, and the case breakdown is seen on this slide. After review of our cases, no patients required any narcotic use after the PACU, and no patients were discharged with narcotics. Our experience during Pacific Partnership 2016 highlighted that host nation policies regarding narcotics present a unique barrier to humanitarian surgery and should always be considered ahead of time. Our success with narcotic-free pain control may reflect a difference between host nation patient populations and our domestic patient population. There are clearly cultural differences in the way pain is perceived and experienced. And with increasing rates of prescription narcotic dependence in the United States, our experience with omitting narcotics from post-operative medications on Pacific Partnership may offer some insight into the management of post-operative pain. From our limited review of our experience on Pacific Partnership, I can conclude that multimodal pain control strategies offer an alternative to narcotics in the humanitarian setting. Our success with narcotic-free pain control calls into question the routine use of narcotics for ambulatory procedures in our domestic practice and suggests potential for future areas of study. Thank you.